But time to move on, and we have some microbiology on the way. And let me welcome my dear friend and my respected senior, Professor Chand Wattal. Dr. Wattal is so well known to everybody who's done microbiology in North India. One of the most helpful seniors and peers that all of us have had, and hugely respected in our zone. He has had 35 years experience in the specialty, over 100 publications, national and international. He's been editor-in-chief of the IJMM and is the chairman of the EQUAS program that runs under the aegis of the national body of the IMM. He's a recipient of several awards, and he recently got, and right from the Hospital Management Asia Award to the Dharamveera Award, he's been a guest lecturer around the country and internationally. Thank you, Dr. Wattal, for spending your time to be with us. And I'd also like to welcome Dr. Jayalakshmi, Prof and HOD of KMCH, Coimbatore. She is not only a microbiologist, but she's also an MBA in hospital administration. She has vast experience in NABL, NABH. She's been guide for PhDs, and she's been a National Advisory Board member. And she has a huge teaching experience. And her areas of interest are quality assurance in medical profession, education, and health. And we'd like to welcome both of you, sir and ma'am, to take this next session ahead.
Good afternoon, ladies and gentlemen. Thanks, Dr. Ahuja, for your kind words. Appreciate, and I also thank the COHO for giving me this opportunity. I'm very glad to have my co-chairperson also here, Dr. Jayalakshmi, and we are poised for, you said that microbiology, but we have a radiologist also here. So it's very good to have a very nice, mixture of these two specialities. As far as the quality control is concerned, we have been listening about the quality issues for the previous sessions. Very interesting area. And then actually I am paranoid as far as the quality is concerned while I am running an EQUAS for microbiology for the North and the Northeast as the second center of IIMM. So we know that also what are the rigmaroles and what it means when you want to be a PT provider and you need to get NABL accreditation as a PT provider, then you know what all it means. So it's not that simple, straightforward. And it's very interesting to have these as sessions so that we get insight into this kind of an activity. So I have my co-chair, Dr. Jayalakshmi. I would request her that she could introduce our speakers.
Sir, it's an absolute pleasure to co-chair with you. And thanks to LABCON and Seema ma'am and the entire team. Excellent job from morning. I think staying on time and much early on time during a conference is itself a great achievement, and having everybody glued to the sessions is fantastic. So it's absolute pleasure to introduce our next speaker for the session, Dr. Rohney Kelker. She's a consultant and hospital infection control at SL Raheja Hospital, and senior consultant for infectious diseases, clinical microbiology and molecular microbiology at Metropolis Healthcare, and honorary visiting consultant for Jerbai Wadia Children's Hospital. Has been working with the Tata Memorial Hospital from the 1st of January 1988 for 32 years, and has established the entire clinical microbiology department, including all the departments of or divisions of microbiology, the bacteriology, mycology, microbacteriology, serology, parasitology, molecular divisions, and virology. And she's got into accreditation of all the divisions by NABL from 2007 onwards, and has also established the Hospital Infection Control Program, including innovation in segregation and treatment of biomedical waste and hazardous waste and general waste. And for this program, she was applauded by the WHO and the central government. And she's received lots of awards and honors. One of them is the Lifetime Achievement Award from the Maharashtra Pollution Control Board for her contribution to environment in the field of biomedical waste management in the year 2004. And it would be wonderful to hear from you. Over to you, ma'am, to listen to you about quality and microbiology, a journey of 4 decades. Over to you, ma'am.
Good afternoon. Thank you for the kind introduction. As you can see, the topic of my talk is a little unusual, but let me tell you that what I'm going to speak is probably an extension of the earlier speaker, and that is evidence-based medicine, laboratory medicine, and how it applies to clinical microbiology. So what I show in the background here is my experience actually over 4 decades, from my student days at the Grand Medical College to the time I joined Tata Memorial, which is really a long time ago. That's exactly 32 years ago. And then what I could achieve over the last 32 years in terms of microbiology. But before I move on to my actual topic, I'd like to share with you the traditional document, and that is the ISO 15189 for microbiology. This is a very elegant publication in the Clinical Microbiology Reviews in 2018. And what this document says, it is about clinical microbiology and quality. What it says is about the 5 quality system essentials, which talk about the quality standards, which have infrastructure of the quality system, laboratory operations, quality assurance, and continual improvement. As you can see, this is probably a repetition of what Dr. Annalise talked about. What is the end point? Of course, it ensures quality, it ensures consistent quality results in terms of patient care. So let's move on very quickly, and I'm going to run you through these slides. The responsibilities of the pre-analytical process. These are all from the same article I referred to earlier. We talk about specimen transportation, collection, requisition forms, then the roles of the analytical process, where we have selection of a test, validation, verification, writing up the SOPs. Then there is the establishment of measurement of uncertainty for quantitative methods. And of course, there is a lot about qualitative methods, which I'm going to talk about in microbiology. To ensure quality test results, which is performance of control, quality assurance, of course, the proficiency testing program. I think all of us who've gone through the cycle of accreditation are extremely familiar with all of these. And this is a document which forms a baseline, which we are aware of, which we are required to follow without any doubt. And that's why I'm running you through this before I go on to the essentials of my talk on quality and microbiology over the last 4 decades. So the roles and responsibilities for post-analytical processes, a review of the results, how are you going to identification and storage schemes, sample retention requirements, and last but not the least, the safe disposal of laboratory waste. Reporting of results is probably the most important component that we all are aware of. Generation of patient reports, and today I talk about it as clinical microbiology being an interpretative science. And that is the theme of my talk today. And I hope that the audience, including Dr. Wattal, is not going to yell at me for this, because I'm talking like a baby, because microbiology is still the baby of laboratory medicine. Yet I think the maturity of about 40 years of experience in the science of microbiology. So the test results, these are all actually taken from the clinical microbiology reviews that I alluded to a little while ago. So let me give you a new dimension to quality. This microbiology alone, it applies to any branch of medicine, in particular laboratory medicine. So what is it that I would like to discuss is subjective versus objective quality. I'd like to tell you that this is actually providing a new dimension to quality, but it's more like talking about evidence-based laboratory medicine. So let me elaborate on what I would like to talk to you and what I want to share with you this evening. You follow the consensus document, which the ISO document, and you will achieve all your quality targets, and the end result is accreditation. But when you look at subjective quality, it requires a strategy. And I know the theme of this conference or this meeting today is strategic planning for quality management issues. Innovations experimentation, wisdom, and you will reach the next level of quality and beyond. So I like to actually, I'm copying the statement, quality should be in your genes. This is from a poster that was made at the Hinduja Hospital by Dr. Ajita Mehta, one of our students in terms of infection control. But what I would like to say here is that yes, quality should be in your genes. So I'd like to start with it's actually not my journey, but it's just talking about quality and microbiology all along that I wish to do today. To be or not to be is Shakespeare's statement. But for me, when I joined Tata Memorial way back in 1988, it was TB or not TB, because the only diagnosis of tuberculosis those days was from histopathology. In cancer patients, there is a huge need for tuberculosis diagnostics because either tuberculosis can present as cancer or a malignancy, it can mimic, or it can coexist with cancer. So there are diagnostic dilemmas, and there is definitely a need for tuberculosis diagnostics in cancer. The first time I went and met my boss for some work on tuberculosis, the question I was asked is, why do you need to work on tuberculosis? I said, sir, I'd like to have a biosafety cabinet. As you're aware, Tata Memorial was males dominated. Today we have a lot of female surgeons. Happy to say that. I had to justify the need for a biosafety cabinet. Why do you need a biosafety cabinet? Why do you need to work on tuberculosis? So with these questions, I actually went on with my crusade against TB diagnostics, or in favor of TB diagnostics, and we had to introduce diagnostics. So I had to begin with making LJ medium because all we did was smears. So how do you make LJ medium? I know that all of us today, I have never done it, but majority of the laboratories, microbiology laboratories today are buying LJ medium or working without it. Unfortunately, this young microbiologist had no way but to make LJ medium. So what did we do? I didn't have an inspissator. So the first batch of LJ medium that I made was in a pressure cooker. I think a lot of the audience who's listening to me will soon start laughing at my experience, but believe me, it worked. And we had to maintain the quality. I had good LJ slants. What was the test of that LJ medium? Monitoring quality of LJ medium became a huge issue for all of us. So, and later on, I realized that the quality of eggs, I needed to get fresh eggs. I had to go to the kitchen actually to get fresh eggs. So when the vehicle came with the eggs, I would actually at the vehicle and pick up the eggs saying, I need fresh eggs. Later on, we realized that one of the issues was that the eggs have to be drug-free. Then the next thing was procurement of biju bottles. You will excuse me because my presentation actually jumps from one point to another. Where do you get these biju bottles from? Where is the vendor? Who's going to give you these? I was working in a cancer hospital and people had not heard of things like this, believe me. Then we've got an inspissator in time to where to store media. What about the growth and the isolation rate? A very peculiar episode we had is one day all my slants got burned. And what was the cause? The temperature of the incubator went for a toss and everything that we had put in it was burned. It's actually been a pretty journey because all along we are just struggling to maintain the quality and produce good quality results because I needed to diagnose tuberculosis in cancer. I had to go beyond histopathology. Then we also got a carbon dioxide incubator, which improved our results. And the final parameter was good isolation rates from clinical samples. I think over the years, this is what we achieved. And we did get very, very good isolation rates, although till the end of processing samples, actually we got all the equipment required. But what used to happen is, how do you incubate the slants? Where do you incubate them? How are we going to observe the results of culture? Then we had to standardize. Once we started getting good growth rates, we had to standardize manual biochemical tests for identification. It's very important to understand that one doesn't give up. Whether you have manual microbiology, you cannot give up because you need to, that patient needs a report. So ultimately, what is critical is that the patient needs a quality report. So we had to soon start reporting the results based on the was presumptively identified as Mycobacterium tuberculosis, a dangerous thought because we were actually identifying and labeling patients as having tuberculosis coexisting or as a diagnostic dilemma in cancer patients. Then we had IT issues for reports, which came up much later, but I'm just going a little fast because I don't think I want to exceed my timing. It's the end of the day, and I'm sure everybody is tired of listening to the same thing about quality. But what was the IT issue? I need to produce a new report every day. So today I say smear positive. Tomorrow I say specimen has been processed for culture. After 1 week, I say no growth. After 3 weeks, I say slow grow or isolated. With the same identification, sometimes the IT system just doesn't allow you to report. So there were just once we started getting good results, I still didn't have any automated system, but here we don't give up. And my advice to you is never give up. If you give up, you've lost the battle. Susceptibility results for patient isolates, we actually standardize the absolute concentration method. Again, I think Dr. Wattal is going to wonder what I'm saying. Dr. Bhargava probably doesn't agree with me, and I'm willing to take on questions on that. But this was a journey which it worked. What worked was the quality of results. We did produce good microbial susceptibility testing results because I managed to procure antibiotics. We managed to get standard strains. I wouldn't steal for sure, but yes, we did beg and we did borrow a lot. We had to have schedules for slants, incubation, and then finally you start growing contaminants, the LGN medium melts. So it's not easy managing the quality. Then came the era of automation in tuberculosis, and I managed to get a TB Bactech, which is a radiometric system, in 2005. Unfortunately, when technology gets upgraded, many of us are not prepared for it. One fine day, I was told that the Bactech is outdated. Now you have to upgrade to the midget. The administration did not sanction me a midget because there were some administrative issues. And lo and behold, we had to return to manual systems. We went on to standardizing liquid cultures because the norms require you to use liquid cultures well for isolation. Then came the era of the Gene Expert in 2015. With the Gene Expert, yes, good system, automated, very, very quick, we could give results. But this is, please remember, this is a genotypic system. And being used to phenotypic methods where I'm seeing a patient, I'm giving a result, and I know that, yes, whether the patient responds or not tells you further whether your report was good enough for this particular patient. In the Gene Expert, you can pick up the DNA, but when it comes to resistance mechanisms, they are genotypic. So there are issues when genotypic and phenotypic results do not match, and you need clinical correlations. Now, the 2021 challenge for me as I am a consultant is establishing quality for next-gen sequencing for mycobacterial drug resistance. So as you can see with TB diagnostics, which I'm using as an example of progress, I'm using it as an example of strategic planning for diagnostics for a microbiology laboratory. Today, we have reached the stage where we are using the highest level of technology for drug resistance and also for whole genome sequencing of bacteria. So what you can learn from this is subjective quality requires wisdom, perseverance, and strategic planning to improve patient services. Enough of tuberculosis. Now let's move on, and I'm quickly jumping scales to basic techniques and infrastructure for bacteriology. When I talk about infrastructure, I mean everything. I mean everything that matters. And to me, what matters most in bacteriology is the technical expertise. And before that, the specimen collection. As we've gone through the ISO document, specimen collection is extremely important. And everything in microbiology depends on the specimen collection. There was a time when the administration decided that they were going to employ even a graduate from a 12th standard graduate as a phlebotomist. Now, what you can see from this result, so to me, it is the qualifications which is important, and microbiology procedures require proper training and further training, not just basic training of microbiology. The test requisitions need to be completed because many times your phlebotomist is not going to be able to do it if the phlebotomist is not qualified. And you can see from this blood culture results that I'm showing in this picture, this is taken in 2015 because that was the year that they employed these, I call them unqualified, excuse my language. Sometimes I tend to be a little rash in my language, but yes, they were not qualified to work as phlebotomists, but an administrative decision, I couldn't overrule it. And what happened was that blood culture contamination rates shot up to 5%, which was totally unacceptable. So here is a point where you need to insist upon the administration. And of course, the administration is required to cooperate because they are administrators. They know their job, but we also know our jobs. And this can affect the quality of results because you can see a lot of blood culture contamination came into being. Again, I'm going to shift gears and take you to another area that the basics of quality. When I was an MD student and my father was my teacher, I remember we were asked to make loops. So we had a little device on which I made a loop because the quality of loop was very important. To me, the bacteriological loop is actually like the stethoscope of the microbiologist. The gauge of the wire, whether you use platinum, nichrome, what is the advantage, whether you can do an oxidase or not. These are things that the present generation has forgotten because what do? We're using plastic disposable loops. I think this is, is advanced, but to me that platinum loop, I still keep a platinum loop. I took it home because I wanted that platinum loop to teach people. This is more like a teaching session. And I believe that inoculation is not just science, but it's an art. And the person I'm showing you is one of my best technologists at Tata Memorial. And you can see she did a brilliant job of plating. The streaking was so good that when I wanted a good plate in front of me for morphology, I would say, I want you to do the plating. So this is when I talk about infrastructure, you have to go to every level to actually identify what are the issues, analyze your quality issues, and then only will you get a good quality result. And this is what I'm calling again as subjective quality. Another example, basic techniques, changing from human to sheep blood. The biggest hurdle for me when I looked at accreditation was how do I get sheep blood? And you'll be surprised if I tell you the story of how we got it. Commercial sheep blood often contaminated, we were just throwing it away. So it was a big challenge. What did I do? We have an abattoir in Mumbai, in Devnar. I ran into the assistant medical commissioner, the assistant commissioner, and with his help, I actually had an arrangement where we had a kit. We would go to the abattoir, and before the animals were being sacrificed, I would collect sheep blood. Then we used to actually defibrillate the sheep blood in the abattoir. So this became a ritual. I don't think anybody in the city of Mumbai, in fact, when I told them the story that I get sheep blood from the abattoir, there were no limits on that. I could get sheep blood from 10 sheep if I wanted to. And that because we had a huge requirement for sheep blood. And I know for a fact that when I was on leave for for a month or so, promptly they stopped collecting blood from the abattoir and they ordered sheep blood from oxide or BD. So this is what I would like to say, that we need to plan, we need to implement, and we need to be innovative if you want to maintain quality in microbiology, which is very, very subjective. And there can't be objective tools for assessing the quality of some of these parameters that I'm discussing. Again, innovations in quality in antimicrobial susceptibility testing. There are some newly introduced antibiotics that we couldn't get this. So we had a method of making this. Sometimes we made this, and I used to make 100 this. Each of those this was inoculated with the right amount of the antimicrobial. Again, we've even worked for drugs like imipenem. I have worked with with a drop which was given to a patient because these are expensive antibiotics. Then we would compare this standard disk from either oxide or BD, and only when we were satisfied that my zone parameters of the patients as well as the quality control strains matched, that we would actually release the results, because there was no way I could have got those discs on a routine basis, and the requirement was huge. Antifungal susceptibility testing also, we've actually worked with spores of Aspergillus. These are manual methods, and I'm aware that even the CDC finally cross-checks everything by manual methodology, despite the availability of automation. Moving on quickly to automation in bacteriology and mycology, let me appraise you of the fact that microbiology is an interpretative science. You need to be a good morphologist to be a good microbiologist. I need to see those colonies. I need to see those organisms before I can actually sign out a report, or before I can believe the report from an automated system. And particularly with yeast, where yeast can often get wrongly identified, and MICs in automated systems are not actual MICs, they can be extrapolations. So all these affect the quality of results, and you need to be aware. You can't just believe machine printed results. Gone are those days. Although automation is good, it cannot be better than the microbiologist or man who behind the machine. Identification of mycelial fungi, again, a huge area of where you require expertise, because you need to see the patient, you need to look at the cultures, you need to understand morphology before you can actually decide whether it is a contaminant, whether it is a pathogen, and what the clinical significance of this is. A quick look at serology. Serology is purely automated, objective today, but we had a different experience when the viral marker screens for HIV, HBV, and HCV were done by transfusion medicine. And when I took it over in microbiology, there was a huge problem because the blood bank was not by regulations allowed to perform diagnostic tests, and we had to do a lot of standardizations in that regard. Sample collections are critical in serology and they affect the results. The interpretations, of course, are very well standardized, but the problems of quality arise when you have a result which is close to the cutoff, and there you need to analyze, and your interpretative skills come into play, particularly with HCV antibodies. With HIV also it happens. So you need to identify when a result is close to the cutoff, what is the range that you're going to accept. Now these ranges need to be established by the department. There are no norms that the company can tell you. They will tell you that 1 is the cutoff, 1.1 is positive, less than 1 is negative, but it doesn't happen that way. And that's where our skills actually come into being, and that is what I call as subjective quality. Reproducibility of results with ELISA systems is sometimes tricky, because manual steps like washing is a very critical step and it's not standardized. So if you have a good technologist, they'll give you a good result. We had this experience with the collective mannan assay when I had to call in one of my ex-technologists who was my teacher actually to standardize the test, because the only thing that was important was the quality of pipetting, and that is highly subjective. There's a lot of variation from person to person, and you need a skilled technologist for this. One last point was the automatic release of results, which requires special inputs. Very often machines, the result is just release, negatives, release. No, it doesn't work that way. You need an interim screen where somebody has looked at the results. Somebody is actually, the technologist will say quality control checks, release results. I'm sorry, it's not so simple. You need a good clinical microbiologist to step in, and that is where the subjective component comes in. Molecular microbiology, a huge area. Yes, Hpv DNA detection, which we were doing for years to get a huge project in Barshi for screening. What happens was with quality issues is results close to cutoff. I remember a patient who had 1 or 2 cells in a pap smear, which were actually which were of ascus nature. I'm not going to go into the details of this, but that was uncertain malignancy, and the results kept coming 1.1, 1.1. I say 3 times. I could not sign out a positive result for this particular case. What do you do? So here, even though the quality of our assay is in order, yes, the huge subjective component, you need to look at the patient, you need to talk. But that's just one example I'd like to share for want of time, and I hope I'm not exceeding my time. RT-PCR for SARS-CoV-2, I've been involved for the last 1 year in looking at this aspect, and I'm aware that using CT values, quantification of viral loads, it doesn't go so easy. Although companies will say qualitative, the clinicians are actually talking about it as that's another big question mark that you need to understand. So the clinicians actually need to understand, and they need to tell you that sorry for the interruption, you need to teach them what is the interpretation of results. So should molecular biologists report such results? The answer is no. Molecular biology, molecular microbiology are different. Can research scientists perform and report? This is what is going on currently. Anybody who's a molecular biologist wants to interpret the results and sign out reports. So let's move on to my last two, interpretative clinical microbiology. Clinical rounds in critical areas very important. A lot of microbiologists are lazy because they want to sit on a machine, sit on the computer, sign out results. That's what microbiologists are doing. That's not quality. Please remember that. Presentations at clinical meetings, clinical case presentation rounds, follow-up antibiotic usage, emergency services, so that microbiology residents are actually giving reports of blood cultures, MDR organisms, reporting smears of biopsies for fungi, etc., and is probably the most important of quality in microbiology, which I'm calling as subjective. And to move to my last few slides, I cannot excuse the speed, but I think I have too much material and too little time. Waste management became a part of microbiology. The chairperson has very nicely introduced all the awards that I've received. But let me tell you, it was an interesting journey. These are the beautiful Idli mountains of Munnar, and I think we are responsible for maintaining this, because disposal of clinical waste has to be done in an environment-friendly manner. This is the system that we had set up, and the waste was sterilized, please remember, dehumidified and shredded, and reduced in weight and volume by 70%. I carried on this exercise from 1999 to 2014 as a part of the department's activities. It was a huge effort at establishing quality and quality results. I'm quickly showing you the posters, the bags, the bins, the sharp containers, all designed in-house, but to quality, the Central Pollution Control Board and the Bureau of Indian Standards. And this is a beautiful picture of the green environment that we maintained in the hospital. So actually the chronology of this, yes, microbiology, when I joined, was a part of pathology in 1988. I've skipped that part, but you can see the journey. It's been a very fruitful journey, and all of it in 2006, we got our accreditation for all the tests from the NABL, and it was maintained and continued till 2019. But what I want to share with you in my last slide is the 2021 highlight, and that is a Latin saying which says primus inter pares. Now, what does this saying mean? First amongst equals. When we follow the ISO documents, you get your accreditation. That is an achievement, but please remember, that is the basic achievement of quality in microbiology. However, let me tell you, when you follow subjective quality through conscientiousness, curiosity, persistence, good communication, and are passionate about microbiology, I think what you achieve is a distinction. Thank you for a patient hearing. Thank you very much.
Thank you, Dr. Kelkar. As expected, wonderful listening to you. A beautiful blend of 40 years. A purist and then a Robinson Crusoe, trying to reach where the quality should be. Grateful for this wonderful talk.
That was wonderful, ma'am, as always.
So some of the points you put right dot over there, you hit the nail on the head. I don't need repeating them. And the beautiful story of the avatar. What was the cost? Did they charge you?
The cost was one trip to the abattoir, which was 300 rupees for a taxi because the hospital didn't give me a vehicle. That's it.
So you could collect as much of blood as you wanted.
That's right. Yes.
That was great. And the part that you trying to talk about the blood blood bank serologies, that is probably, or the molecular testing for the blood donations actually needs the interpretations, and it should go straight to all the blood banks, that they should utilize the services or appoint a clinical microbiologist with them so that they have the right interpretations for the safety of the patients. That point was very well taken.
It is an excellent talk, ma'am. Your 40 years in 20 minutes was actually trying to put them all together so quickly. Wonderful listening to you. Thank you, ma'am.
Thanks a lot.
Thank you, Dr.
It's been a pleasure.